Hey guys, welcome back. I am here with my friend and colleague Eric Rhoden from Neurology Solutions. He is an Austinite like myself. If we haven't met, my name's Sarah King, physical therapist, founder of Invigorate Physical Therapy and Wellness in Austin, Texas. And so we're in Vancouver, but we're both from Austin, and Eric is actually from San Diego and came to Austin and has been an awesome addition to our community, and he is really my go-to expert when it comes to deep brain stimulation and everything, the who, the what, the where, the when, the how of DBS. I kind of leave it up to this guy. So I have a lot of questions that you guys sent me about deep brain stimulation that you were hoping I could get answered here in Vancouver. So I am going to kind of lightning round Eric with some questions and answers about DBS. So if you have more questions, you can put them in the comment section below, and if I see him, I can ask him too, put him on the spot a little bit. Yeah, so put your questions in the comments, check in, let us know where you're checking in from, and again, he's an Austinite. So you ready?
Yes,
okay.
Thanks for having me.
Yeah, for sure. So my first question is, when should someone consider having deep brain stimulation?
That is probably one of the number one questions we get in our clinic and just, well, throughout anybody, whether it's PT, neurology. And the answer depends. I know it's a terrible answer to the question, but the reality is that that's true. The prior kind of standard was, it used to be the last resort treatment. Was, okay, you've utilized every medication cocktail imaginable. Now let's throw in for deep brain stimulation. That paradigm is almost flipped on end, and there's been a much larger push for early intervention of DBS. And the thought process there is you actually will hopefully prolong your ability to utilize medications in a better capacity because you're going to have less off times throughout, so you don't need as much medication if you're utilizing DBS earlier in diagnosis. And as far as how early, I mean, I've had people 3 months diagnosed that have had deep brain stimulation, people that have had DBS or Parkinson's for 30 years, and it really both do well. Not everybody does great, which we'll lead to later. But as far as when you should get it, it's really that conversation you have with your neurologist, your therapist, is if you are having this drastic off-cycling motor fluctuations where you're just not being able to control your symptoms correctly, DBS, Duodopa, newer stuff coming on the horizon may be the choice for you.
Awesome. So I guess my follow-up to that is, I know somebody's asked me before, why not consider it as kind of like a primary intervention with Parkinson's? So I think big question is, what symptoms does it help with? What symptoms maybe does DBS not help with? And then do you ever see patients get DBS before they're really symptomatic, when they maybe just have mild symptoms of Parkinson's?
Absolutely. No, it's a great question. In regard to which symptoms they tend to work the best with, it tends to be kind of your triage of tremor, rigidity, bradykinesia, that world. It does not fix postural instability. So that is one thing that I think a lot of people expect to change, where all of a sudden their balance is drastically going to improve. Now, I say that with a little asterisk sign, mainly because it depends on the source of your balance issue. Now, if you're rigid and you're stiff and you're unable to break out of that bradykinesia, that slowness of movement, if that's your source of balance deficit, then yes, that will improve in some manner. But if you have an underlying postural problem, which you would be teasing out with your therapist like Sarah or myself, that may not get better. The only way that's going to get better is with good therapy. Freezing of gait is, again, that kind of mix there. There's a lot of people, it's not one of the ones we campaign to be able to fix with DBS, but again, going along that rigidity component, if that's your cause, it may help with it. We had a recent patient where that was his main complaint. We switched him on. He hasn't frozen since he got DBS, so that was a great success for him. There are other people, not so much, and the question comes, well, why did that guy work versus the other one? And a lot of it it comes back to the etiology and kind of the progression of the disease, depending on where it's hitting in the brain, in particular your executive function, so that high-level thinking, the frontal cortex. that spot of spatial reasoning lives there. So how we manipulate, problem solve space, and if that has a deficit, that can exacerbate these freezing of gait moments. In addition, anxiety, stressors, so if you're a little more of an anxious person, stressed out person, learning relaxation techniques, breathing techniques, yoga, again, all stuff that you want to be working on with your therapist.
Awesome. Super plug for physical therapy. Woo. Don't act surprised. We're both drinking the Kool-Aid. So my next question, so as people are considering getting DBS, what is the process that you go through once you're starting to consider DBS, like from the very beginning to post-surgical, in a nutshell?
Yes. So it varies facility to facility depending on the movement disorder doctor. However, generally what you do is you have to do a on and off state testing, normally using the UPDRS, which is the Unified Parkinson's Disease Rating Scale. So it's basically kind of this arsenal of questions and tests, motor and medication based, that you answer, and you get a net score. They're looking at your total score as well as your motor score in particular, because those tend to be the complaints and the things that we work on the most for DBS. You do an on state, then you wash all your Parkinson's medication, which everybody hates to do because you feel terrible, and then you retest all those same things that you did in the on state, and you see if there's enough of a difference. Now, in general, again, this varies facility to facility, but we normally want to aim for 20 to 30%, aiming towards that 30% plus mark of a difference between your on-state, off-state to show that true benefit of DBS. In addition to that, if you're showing any signs of cognitive impairment, they may send you for formal neuropsychology testing, which if any of you have ever been through that, it is daunting. It's a 6-hour event where you go to a neuropsychologist and they are asking you questions, making you do tests and draw these silly pictures, but the rationale behind that is there's some research that shows certain areas in the brain, in particular the STN, if you already have cognitive impairment, it may exacerbate that to some degree. So they want to make sure you don't have an underlying cognitive issue beforehand.
Awesome. So then they go through the process of having brain surgery.
Yes.
Which is a big fear. Maybe we can come back to complications later, but so they undergo surgery and the post-surgical, kind of what's that process?
Okay, yes. So at least currently, how they normally stage the surgery is you'll come in one day, or you'll get your surgical consult, as long as you don't have any other comorbidities or complications based on your scans of the brain, then okay, let's say you're a good candidate. You'll go in and you'll get these things called fiducials, which are probably the most painful of the entire surgery component. Basically, they drill in these little antenna spots where they have to mount the structure to actually place them. That's the most painful thing. That happens the day before you actually have your DBS placement put in. Day of, they basically put about nickel-size to quarter-size holes on either side, depending on the structure where they're looking. If you're essential tremor, you're looking at VIM. If you're Parkinson's, you're looking at STN or GPI. Again, as far as which one is which, that's a whole other topic of discussion. Ideally, they make their pass, they hit it clean, they do a reading on you, intraoperatively. So a lot of people get freaked out because most doctors do the surgery awake, meaning you are awake while they are in your brain. A little scary, a lot of people freak out. However, most doctors, they put you in a semi-sedative state. So it's kind of like you're just relaxed, you're able to follow directions because they are actually testing you. So that goofy, they make you do this and move your hand back and forth. They will do that intraoperatively when they are stimulating the structure in the brain because, let's face it, they want to make sure they hit the right spot. Just because a picture shows it doesn't mean clinically you're getting it. So they do that, you get dialed in, and then sew you back up, everything's good, and then the post-op care is where that varies drastically too. So our clinic, we go right away. You get your brain surgery. Within that same week, you get your IPG, which is your battery and computer. That can be placed in numerous sites, and a lot of time it's either the chest or our facility uses the abdomen, and a lot of it for females and comfort, it tends to bother people up in the chest area, so we tend to move it down to the abdominal area, and it seems to work a little better as far as comfort. There's some new tech coming out there in the future, hopefully, smaller batteries, stuff like that, where hopefully it'll be less of an issue. Other facilities, they will wait 4 to 6 weeks after your surgery before they even touch you. Like I said, we jump into it week 1 and we chase your swelling and try to get you dialed in as quickly as possible and at least get you some control, because after all, you just went through brain surgery. So in our mind, why wait?
Yeah, awesome. Very nice, very nice. Okay, so I would say maybe you guys can give me a thumbs up. Make sure that we're talking loud enough. We're using my headphones here, so if we are too quiet, please let us know. Judy asks, what if you are ET and PD? Okay, let's bookmark that. You feel confident answering that one in a little bit? Okay.
It gets complicated.
Okay,
yes.
It gets complicated. Okay, we're going to save questions for the end. So my next question is kind of maybe a brief overview of the types of DBS and maybe what's coming down the pipeline.
Okay, yes. All right, so currently, well, at least up until the last few months, it was Medtronic was the only, they were a monopoly in that sense. They were the only product out there. Now, elsewhere and internationally, there's a lot of other companies that have been there, and they may be coming to the U.S. soon, which is great. Recently, there's a new one that has come out by Abbott called the Infinity Stimulator, which is a directional DBS. And it used to be prior called St. Jude, but Abbott has now bought them at this point, so they call it the Infinity. The benefit that they are promoting with that is this directional component. So let's say you have 4 leads on this side of the brain, so you have 4 contacts. These 2 middle contacts are split into 33-degree pies. So people say, well, why do you need that split? Well, let's say you're getting an odd side effect when I turn on these particular leads in the middle while I'm programming you. Let's say you start slurring or you get facial pulling. I'm thinking, oh, we might be close to a particular structure in the brain. I can actually direct the electrical field away from that structure and ideally not have that problem. Now, Medtronic also does that to a certain extent. It doesn't do a directional, but they do a thing called interleaving, which is basically they put 2 programs on one side and it's going back and forth, and that reduces the activation of those particular tissues. Now, down the line, I think realistically everybody's going to have a directional lead. That is kind of what is being foreseen in the future. As far as which one's going to be better, that's kind of up for debate depending on who your neurologist is, who your surgeons are. But the good part is competition is good. I like it. It adds a different dynamic now. Hopefully brings down the cost of everything, which is also a good thing. So, yeah, we're excited for it. New tech is good.
Yeah, new tech is great. New tech is always welcome in the Parkinson's world. I'm seeing that some of you are sharing this video. I really appreciate it. I know that it's going to help so many people. So if you are watching this and you feel like it's valuable, please share and ask your questions in the comments. We're going to get to those here in a second. I only have a few questions left, then we'll talk about Judy here. But my next question is for those people who have had DBS. They're have everything post-surgically healed and they're in the rehabilitation process. How do people know that they are not kind of at an optimal setting, their stimulation setting? Maybe they're overstimulated or not stimulated enough. Maybe an overview of how to identify when that's going on.
Absolutely. So the goal normally, again, of DBS, right, is to get better management of your symptoms, but ideally also reduce medications. At least that's normally the aim, to reduce that off-cycling phase. So, one, if you're having less off-cycling, that's a good thing. If you're still having that same amount of off-cycling once you've had DBS, there may be an issue either with not enough stimulation, not good, basically, medication management. Maybe you're not having enough frequency or not enough of that medication to get you through and have less highs and lows as far as symptom control. So that's one just kind of easy way. As far as side effects of if it's not working enough versus working maybe a little too much, we frequently hear, I feel overstimulated, kind of like you're wired, you just had a shot of espresso right before bed. That might be a feeling of overstimulation. Maybe you just turn yourself down a little bit and you'd be good. The other component, a big one normally, is dyskinesia. So dyskinesia is that uncontrolled kind of movement. It looks like you're almost dancing. It can be in your neck, leg, arm, even whole trunk. That tends to be the most common side effect of overstimulation and over-medication. Because again, when you're trying to do this, here's your medication, here's your DBS, it's electronic medication. So as I'm increasing this, ideally I should be able to decrease my medication. That's what we're playing with. It's that perfect cocktail of the two. And especially early on, sometimes you get a lot of these fluctuations. As far as understimulation, it tends to be your typical symptoms that you get: rigidity, your tremor returns, maybe even cognitive slowing. That tends to be, I think, a little bit more lack of dopamine pharmaceutically. So using levodopa, using Rotari, again, that can go into a different talk as far as the cognitive component with dopamine. But that is something you want to look out for, because you need to have that perfect mix of the two.
Perfect. Do you have any other words of advice for people who have had DBS and they don't feel like it's been as effective as they want it to be, or does that kind of cover most of your suggestions?
I mean, the easiest one, not that I recommend this to everybody, is if you don't feel like it works, turn it off. You have your remote, turn it off, wait, see how you feel. If you're like, oh my gosh, I feel terrible, or my tremor starts going out of control, it's obviously doing something for you. I mean, it seems like a cheap answer, but the reality of it is that happens. Now, I will put another asterisk by that answer is you get a carryover effect in some people, meaning I can shut off the DBS and that person may look perfect, the exact same they did on DBS for 10 minutes, for 5 minutes, for 5 hours. And then all of a sudden their true nature of the disease comes back. They talk about this lesioning effect, or this honeymoon effect that you get post-surgery, where all of a sudden your symptoms are magically better even though the DBS isn't actually on. And it's just that aspect of putting something in your brain in that area of your body reacts that way. Well, it's to a similar manner, it's that way when you turn it off. Your body, psychologically it thinks, oh, well, it's still there, when in fact it may not be. And then all of a sudden it realizes, oh, we don't have the juice that we need, and now you start seeing your symptoms. So you got to play with that a little bit. And really it's looking at it in a long-term way. Is, okay, how was I before surgery? Okay, I was popping Rotari or Cinemet 6 times a day, and I was having off-cycling every 2 hours, and I still didn't have good tremor control, and I couldn't think clearly, or I had lack of focus, versus now, okay, I am still taking 6 times a day of Rotari or Cinemet or an agonist, but now I can go 4 hours without an off-cycling moment. It's not perfect by any means, but that's a pretty significant improvement from 2 hours to 4 hours. So it's a relative thing. You got to give a certain perspective of progress. We use this all the time in physical therapy. People say, "Oh, I'm not getting better." And it's like, well, what are you measuring? You got to look at what you're measuring, and there probably are gains that you may not even be aware of.
Awesome. Great answer. So we're going to shoot through these last 2 questions. I want to go ahead and acknowledge Judy's question here. We're running out of juice on my phone camera here. But Judy asks, what if you are essential tremor and Parkinson's? So what do you have to say for Judy?
So that gets a little tricky, obviously, because they are different target structures when you are doing DBS. A lot of the time we'll see patients where they may start with Parkinson's-like symptoms, Parkinsonism, or start with ET, and then it manifests into both. Unfortunately, they seem to be kind of cousins to each other as far as etaology and what's going on in the brain. Now, as far as what target site, in all fairness, it's the depends word again. I hate to say it, but which symptoms are more debilitating in nature? Now, there are a few people that have both VIM and STN surgeries, meaning they have double placement on both sides, trying to correct essential tremor issues as well as Parkinson's. You can agree to disagree. That's an argument, I think, with your neurologist and neurosurgeon if they actually feel that that's going to help you or not. I would go after your more debilitating issues as far as, is it the action tremor that you're grabbing for something? Is that the thing that frustrates you the most? Or is it the fact that you cannot move? You're getting this freezing, you're getting this rigidity. Is that more problematic for you? So I'd aim for what's the stronger clinical manifestation and relation to your quality of life more than anything else.
Awesome answer. Awesome. Hope that helps you, Judy. So last question before we sign off here is I've been getting a lot of questions about the functional ultrasound coming down the pipeline, the non-invasive brain surgery option. So what could you maybe give us some insights into functional ultrasound and what you know?
Yeah, so my brief knowledge on it, hopefully there'll be more to come, even learning from here in Vancouver, is it's appealing, right? It's non-invasive. I don't have to have anything drilled into my brain. They just set me up, they shoot in the ultrasound, and ideally, magically I'm better. Now, what actually is occurring is a focal ultrasound. So based on the trajectories of how they're pushing this ultrasound into your brain, their argument is it causes minimal damage, really no damage to any of the structures prior, but that intersection point of all the different vectors of ultrasound exaggerates, and basically it heats up, and it's essentially like a laser that pinpoints that particular area and structure, and then ideally your symptoms go away. So as far as the technical components of how they figure out exactly what spot in the STN, VIM, or thalamus to target, that I am not familiar with, but that's their goal. It's an ablation of that particular site, meaning they kill that tissue. Now, again, you can argue, okay, that's great, non-invasive, boom, it may fix my symptom immediately, but as we know and as you all experience, this is not just a disease of the brain, this is a systematic problem, and there's a lot more going on than just killing one spot. So I think it is a good alternative. As far as long-term benefit, it's too new to say. So I think it's a great other alternative for people that maybe can't have deep brain stimulation. Maybe there's structural issues that don't allow them to have that point. Maybe focalized ultrasound is their best option at that time.
Perfect. Wonderful. Well, thank you, Eric. That was very
Sarah.
insightful. If you guys have any more questions for Eric or just about DBS or anything related to functional ultrasound or any questions you have, put them in the comment section below. We'll keep an eye on them and see if we can give you guys more resources as the conference continues. So we're going to sign off here and head into our next workshop. So thanks, Eric.
Thank you all for watching.
Yeah, we'll see you guys soon.
Take care.
Bye.